Yeah. Fair enough. All right. So where we stopped last time was, yes. The who? Okay, Justina. Sure. I'll do it right now. Thank you for telling me that. All right, give me 1 second. All right, it should be sent to her. All right, so where we stopped last time was, if this is ever going to work, the difference between internal abdominal oblique, external abdominal oblique, transverse abdominis. And if you remember, we kind of ending class on Wednesday talking about, well, we're going to talk about how these all go in different striation patterns, which is going to really, really be important for what each of these motions and each of these muscles do. So where we're going to start with this is we're going to start with this with the easy one, which is waiting for Microsoft Teams to actually do its job. So the easy one is going to be transverse abdominis. Well, this is not going well today, is it? So transverse abdominis, its muscle fiber striations go in the transverse plane, right? Okay. So literally, easiest way to remember this is take your fingers, put it on your abdomen, and pretend like the muscle fibers go in the direction of your fingers. So transverse abdominis is going to, when it contracts, contract in the transverse plane. Transverse abdominis is going to increase intra-abdominal pressure. For those of you who have worked in PT clinics, observing PT clinics, one of the first exercises that PTs like to do with their patients is do an ab crunch or ab iso or some activity like that, right? So essentially what they're trying to do is contract transverse abdominis. You guys, in fact, may have helped a patient or two with this sort of thing. So who's done transverse abdominis exercises with the patient? How do you cue that patient in transverse abdominis exercises? What do you tell them? Bring belly button to the spine, okay? Pretend like you're bracing for a punch. Okay, now, and I'm not saying you guys are wrong. Let me ask you this. When I bring my belly button to my spine, what's a patient going to do? Okay, is that necessarily contracting transverse abdominis? What do you think? Maybe, maybe not. Okay, because if transverse abdominis is going to increase intra-abdominal pressure, if I tell my patient to take their belly button to their spine, I'm actually not increasing a lot of intra-abdominal pressure there. Okay, all I'm really doing is basically having them lift up their rib cage a little bit, which creates extra space. Transverse abdominis is going to be contracted when I tell my patient mostly to brace themselves, right? So what I want them to do is I want them to contract and make this a very hard feeling object, okay? So transverse abdominis, really super easy. Increases intra-abdominal pressure. Internal abdominal oblique. Okay, remember that's my up and in muscle, right? Right. Okay, so internal abdominal oblique, up and in. Internal abdominal oblique is going to, when innervated unilaterally, it is going to make my patient side bend or laterally flex their trunk ipsilaterally. Okay. You guys remember what ipsilateral is? Same side, okay? So internal abdominal oblique, innervated unilaterally. So in other words, if I only zap the right side, I will get same side lateral flexion or same side bending. When innervated unilaterally, it will also cause same side trunk rotation. So when I zap the right internal abdominal oblique, it will cause same side trunk rotation. Okay? When internal abdominal oblique is innervated bilaterally, okay, so now I have right and left getting zapped, what I will get is trunk flexion. And the reason I'm going to get trunk flexion is because of those vectors that we talked about last time. Okay, so if I have a vector going to the left and a vector going to the right, those are going to cancel each other out, right? I have a -1 on one side and a +1 on the other. Add them together, I get 0. Same thing with rotation. If I have a -45-degree vector on the left and a +45-degree vector on the right, they will cancel each other out. The only thing that's going to be left is going to be flexion. So when left internal abdominal oblique and right internal abdominal oblique are innervated, I will get trunk flexion. Okay? And the reason I'm spending so much time with this, I'm guaranteed there's going to be some test questions on it. And these are typically the ones that trip up students on testing. Okay? Yep. So this one's internal. So transverse, internal. Okay. Any questions on those two so far? Yes, ma'am. They will do pelvic tilt. So when you actually hold down somebody's rib cage, they will posteriorly rotate the pelvis as well because they attach into the pelvis. Internal oblique will definitely help with that. I don't think this is working at all today. That's terrible. Well, it's okay. We have equipment that's running programs that it wasn't meant to run. So then external abdominal oblique. Okay. So we've done straight in towards the belly button. We've done straight up towards the rib cage. Now we're going to go down. Okay. So external abdominal oblique, my fingers are running down and in. When I unilaterally innervate external abdominal oblique, I will get same side ipsilateral side bending, but contralateral rotation. Ipsilateral side bending, contralateral rotation with external abdominal oblique. So if I want my patient to contract their right external abdominal oblique, it's going to drive their right shoulder to their left hip. Okay? And in fact, if you guys put your finger right on EAO, you can feel it contract as I drive my right shoulder to my left hip. Notice on the other side, if you put your finger on the other side, I really don't feel that muscle contracting. At least I don't. Okay? So transverse abdominis stabilizes lumbar spine because of its attachment in through the thoracolumbar fascia. also increases intra-abdominal pressure. That's why we use it as a, quote, core muscle. Internal abdominal oblique, innervated unilaterally, same side rotation, same side bending. External abdominal oblique, same side bending, opposite side rotation. Yes. That was my next point. You got it. No, you're fine. You're fine. You're allowed to work ahead. It's encouraged. So when I innervate external abdominal oblique, it's going to follow these same vector canceling out rules that I've seen the entire rest of the time. I got a vector going this way, I got a vector going this way, and a vector going this way, and a vector going that way, right? I got all these canceling out vectors. All I will be left with is going to be trunk flexion. So when I innervate EAO bilaterally, I get trunk flexion. When I innervate IAO bilaterally, I get trunk flexion. When I innervate IAO unilaterally, same side rotation, same side lateral flexion. When I innervate EAO unilaterally, same side lateral flexion, opposite side trunk rotation. Okay, that's a lot. Everyone doing okay with that? Any questions with that? All right, so then let's come up with a little practice question here. My patient has a dysfunctional left EAO. It doesn't work. They took it out surgically in a radical procedure. It's gone. Or, as I'm famous for, he was stabbed with some sort of prison shank or toothbrush or something, right? Right, some sort of buzzsaw made out of, like, I don't know, barbed wire. Something fun. When I ask my patient to rotate, so the left side's gone. When I ask them to rotate their trunk, will they be able to rotate to the right, or will they be able to rotate to the left? Who's going right? Who's going left? Left side's the injury. This one's gone. So left EAO is gone. They will have a lot of difficulty rotating to which side, right or left? I got a little bit of both. Yes, Kat. It does. That's correct. Okay, did you guys get that? Okay, so then what we need to think about is what muscles are going to produce side bending. Okay, so if I'm going to side bend to the right, what two abdominal muscles are going to make me side bend to the right? Which ones? Right internal, right external. If I'm going to rotate my trunk to the left, which two muscles are going to make me rotate to the left? Right external, left internal. Okay. If I'm going to rotate to the right, what muscles are going to make me rotate to the right? Right internal, left external. Right. It's going to be extremely weak. Right. So you're still going to be able to do it because the other side abdominal is still going to be contracting, but it's going to be really, really super weak. Does that answer your question? Yeah, good. You guys hate this answer? Go ahead and say it. Go ahead and say it. It depends. because I honestly have seen folks with really super duper strong external abdominal obliques and really underperforming internals, and I've seen the complete opposite. So I mean, you give me 100 patients, I'll show you 100 different patients. So I hate giving that answer, but sometimes I just have to give that answer. No, not really, because I will also argue that folks are going to adapt as well. So what will end up happening is they'll end up hypertrophying the still existing muscle. Now, will it get back to 100%? Probably not, but it is possible. I've seen some humans do amazing things, but they'll probably always have a little bit of weakness. Does that make sense? Now, sometimes that weakness, you would only see it on a manual muscle test. Functionally, they're fine. Yes. Mm-hmm. Mm-hmm. No, that's a great example. That's a great example. So, in unilateral athletics, right? So, golf is a unilateral athletic. Baseball, if you're a DH, it's definitely a unilateral athletic, unless you're a switch hitter. And I would even say tennis is unilateral as well. Yeah, you're exactly right. So you're going to have one set that's way stronger than the other set. Also, you're going to have one set that's way more coordinated, right? So I mean, you guys haven't had a ton of neuro yet, but you've had a little bit of tests and measures. What's coordination really? Like what is coordination? Yeah, ability of the brain to connect to the muscle, the ability for the brain to direct the muscle, right? So that's the other point too, is you're going to be way more coordinated. Like for example, I see all of you guys writing with one hand. No one's really switching from hand to hand. Why is that? It's you're more coordinated with it, right? Exactly, and there's a lot that goes into it. It's outside of our one ambidextrous person, I recognize, but there's a lot that goes into that simply because it's not just hypertrophy and the size of the muscle, it's also how you use the muscle. So you guys probably know from XFIS, kines, those sorts of things, the first 8 weeks of a training program, you don't see a ton of hypertrophy. It's all neuromuscular adaptations, right? Neuromuscular adaptations is simply how well can I direct my body? How well can I fire? Okay, good questions, very good questions. Any other questions before we move on? Yes, go ahead. You're not going to specifically isolate one or the other. What you're going to end up doing, because they work in conjunction, is you'll end up working both at the same time. I'll be quite honest with you, who cares, right? As long as you achieve the functional pattern. You know, in my opinion, it doesn't really matter how you get there. So the only true way to isolate would be you have to use a probe. So you guys will learn about that a little bit in biophysical agents, where you, at least back in my day, we used to take a 66 volt battery attached to a probe, and we used to shock muscles. Yeah, that's way back in the dark ages. Yes. You got to remember, like, I went to PT school way before there was Google. I know it existed. All right. Any other questions on the abdominal muscles at all? Overhead projectors. Wait, overhead. Yeah. Like PowerPoint was just a thing when I was in PT school. All right. Any other questions on that? Okay. So next thing I want to kind of go into is going to be the lumbar plexus. Okay. What's that? I know. All right. I'll make you a deal. We can either go over lumbar plexus now, or I can do okay, now rip the Band-Aid off. Rip the Band-Aid off, right? All right, we have two plexi this semester. That's it. I promise you. We have 2 plexi. I will promise you as well, they are nowhere nearly as complicated as the brachial plexus and nowhere near as complicated as that godforsaken cervical plexus. I can't stand that cervical plexus. Yeah, it's a pain, isn't it? All right, so lumbar plexus. Okay, because I'm going to see if my pen will work here. Aha, it will work. Look at that. Yeah, what's up? What's it? Never mind. Talk to me. The rectus abdominis? Sure. No, that's fine. Let's go over rectus abdominis. I'll tell you what. Let's do this. Let's go over rectus abdominis and let's go over rectus sheath. How's that sound? Okay, so rectus abdominis. That's the easiest one of the bunch, if you remember. Okay, so if this is the linea alba, okay, and there's my umbilicus. Rectus abdominis, and I will apologize because the computer's doing wacky things today. So this is all going to be in the same color. So rectus abdominis is going to come down and it's going to attach into the pubic tubercle. When we cover the inguinal canal, we'll cover the pubic tubercle a little bit. It's also going to attach into something called the pubic crest. Okay. It's also going to attach into something called the pubic symphysis. We kind of covered those on Wednesday. Those are all going to be where it attaches into the pelvis. So these are all pelvic structures. It's also going to attach in to ribs 5 through 8, 5 through 7, 5 through 8. No one is, it depends. I'll put 7 because that's what Grace says. And the xiphoid process. Its action is pretty easy. Okay, so a rectus abdominis muscle. What's the word rectus mean? Right, long, straight, erect. Abdominis simply just means abdomen, right? So rectus abdominis is going to be the long, straight muscle of the abdomen. Now, rectus abdominis is simply going to, when contracted, it'll do one of 2 different things. When the trunk is able to move, it's basically going to bring my rib cage towards my pelvis. It's going to create trunk flexion. When the pelvis is moving, so in other words, my pelvis is free, it's going to bring my pubic crest, pubic symphysis, pubic tubercle towards my rib cage. So posterior pelvic tilt. And we're going to get into this whole pelvic tilt thing a little later. But basically, it's either going to bring my costal cartilage downward or it's going to bring my pubis upward. Okay, both of those are going to create trunk flexion. Now, one thing that I want you to kind of remember and burn this one kind of in the back of the old brain stem is that when I have trunk flexion, I'm also going to have lumbar flexion. And that's one of those things where that's going to be one of the more difficult concepts during this semester is keeping track of everything that's moving. Because you guys probably saw from the readings, muscles like psoas major, right? Does that one sound familiar? Where does psoas major originate? Anterior surface of the lumbar spine, the discs, transverse processes of the lumbar spine, right? T12 down to L5. One of the major motions of psoas major is lumbar extension. So we commonly call psoas major or iliopsoas when it joins with iliacus the hip flexor, right? Oh, they got tight hip flexors. Well, a tight hip flexor can do a couple different things. It can decrease hip extension. It can also increase lumbar extension or lumbar lordosis. And quite often we see this in the clinic. We have a lot of folks that come in and they have a lot of lumbar lordosis going on. They have a huge amount of curve in their back. And in a lot of cases, that at least to some degree is due to the fact that they have tight iliopsoas muscles. Okay, so you kind of have to understand that relationship. Does that make sense? Okay. All right, so from there, did I cover rectus okay? Okay. I'm just kidding with you. So the other thing I kind of want to cover here, let me scroll down here, is the abdominal fascia. Again, I apologize that I don't have different colors. I normally do this with different colors. So the abdominal fascia is kind of interesting in the fact that I'm going to have 3 layers of fascia, but rectus abdominis is going to be encased in different layers of fascia depending on where I am in the abdomen, right? Just to make it confusing. So the first one that we're going to draw here is going to be, well, that's really getting screwy. Who laughed at my computer? Kaylee, did you laugh at my computer? I know. What was that? You said I write like a 6th grader? Jeez. My gosh. Is there anything else you'd like to criticize me on? Oh, okay. Oh. All right. So here's how this is going to work. Okay, so this is going to be anterior, and this is going to be posterior. Okay, or this is going to be the most superficial, and this is going to be the deep. Okay, so we're going to have layer skin. Then we're going to have subcutaneous tissue. We're going to put sub-Q. And then we're going to have our 3 layers of muscle. But first I'm going to draw in, because this is the cross section, these 2 little potato looking structures here are going to be rectus abdominis, RA. So RA, rectus abdominis. What we're going to see here And I'm going to draw these other muscles in as little triangles. And you'll see here why in a second. So this is going to be EAO. And over here, this is EAO because we have a right and a left. Then we're going to see IAO. IAO is obviously going to be internal abdominal oblique. And then we're going to see TA as the deepest. And in fact, what I'm going to do one change here. I'm going to put my rectus abdominis back here a little bit more. Apologize about that. So what I'm going to see is that if I am higher than, superior to the arcuate line, and remember what that arcuate line is. Arcuate line is going to be that spot where the muscle fibers start to arc a little bit. Okay, we kind of talked about that a little bit on Wednesday. The fascia from EAO, remember, it's going to dive into or blend in with the linea alba. So if I draw a dotted line here to represent the linea alba, EAO is going to stay superficial to rectus abdominis. It's going to stay there. IAO, this is the weird thing that happens above the arcuate line. Its fascia actually splits and kind of envelops rectus abdominis. So above the arcuate line, the fascia from internal abdominal oblique splits, envelops or surrounds rectus abdominis, and then meets in towards the linea alba. Transverse abdominis stays deep to all of this. Now, the reason I'm drawing it above the arcuate line first is what we're going to see is that below the arcuate line or inferior to the arcuate line, this orientation is going to be different. Tell me when you guys are finished with the picture. One more time, I'm sorry. So deep to the other two structures. Yep. So it doesn't split. It doesn't come arc around anything. It stays deep to all that. So essentially, if you can kind of imagine, this is going to be a really weird example. Okay, so imagine rectus abdominis being a French baguette. Okay, right? I'm gonna have, you know how like you go to Panera and they wrap like the pieces of paper around the French baguette? Imagine one layer of paper coming over, and that's EAO. They put a second layer of paper deep to that, but they split it in half and put one half above the French baguette and the other half below the French baguette. That's IAO. And then they put an entire sheet all underneath of it, and that's TA. Make sense? Okay. I just had Panera yesterday, so that example works, right? It's Panera, right? It's like, hey, you know what goes really well with the bread bowl soup is a thing of bread. Right, exactly. Lots of starch. Yeah. I'm on the North Beach diet. What can I say? All right. So any other questions about what happens superficial to the arcuate line here? Good? Okay. So let me erase this out. Now we're going to draw out below the arcuate line. All right. So below the arcuate line, we're still going to have our layer of skin. We're still going to have our layer of subcutaneous tissue. We're still going to have our three muscles. So EAO, IAO, and TA. And we're still going to have our rectus abdominis. Not potatoes this time because someone didn't like my reference. Okay. Pet rocks. We're going to go with pet rocks. So when I am deep, I'm sorry, not deep. When I'm inferior to the arcuate line, here's the different orientation that's going to happen. Okay. EAO and its fascia is still going to ride superficial to rectus abdominis. The fascia of IAO is all going to ride superficial to rectus abdominis. So the entire layer of fascia, the entire sheet of fascia is going to stay superficial. You don't see splitting below the arcuate line, and that's the huge big example. So internal abdominal oblique will split above the arcuate line, and it will not split below the arcuate line. The other thing that happens here is that transverse abdominis does its thing, and it's going to stay deep to rectus abdominis. So what I want you guys to do is start thinking about test questions, right? So here I am a abdominal surgeon, and I need to insert a needle in through the abdominal cavity. I'm going to insert that needle above the arcuate line. How many layers of fascia will I go through before I hit rectus abdominis? Above the arcuate line, here's your options. 1, 1.5, 2, 17. Gotta put a throwaway in there. Who's going 1? Who's going 2? Who's going 17? Really? Who's going 1.5? Okay, what makes it a half? Because the entire layer of fascia isn't superficial to rectus abdominis. Half of it's going superficial, half of it's going deep. Make sense? So it's a little thinner layer of fascia. Now, I'm going to be quite honest with you guys. You will be able to see some of this in the cadaver lab, but we're talking like razor thin layers here. So don't anticipate that they're going to be like huge chunks. I mean, we're talking like, I don't know, what would be a good example? Like a piece of wax paper on top of another piece of wax paper. And they're glued together, and I say split them apart. Yeah, yeah, pretty much. Yes. It'd be, yeah, if it was below the arcuate line, you would go through 2 layers of fascia because you're going to go through both full layers of internal abdominal oblique and external abdominal oblique. Yeah. Transverse abdominis come. No, transverse abdominis fascia. You were right. Yep. Let me redraw that. It does. It does. Yeah. So that goes in front too. So they all go in front. So you go through 3 layers. 1, 2, 3. My mistake. Sorry about that, guys. Okay, so below the arcuate line, like I said, I made a mistake. EAO, IAO, TA, all going to come superficial around. Yes. So technically there's 8, but that's another one. It depends. Usually the very lowest one is not very well developed at all, but there's technically one that's sitting down at the pubic symphysis. So remember, arcuate line is going to be halfway in between the umbilicus and the pubic symphysis. So I could still technically have one here, one set, if you will, and then another set inferior to that. Yeah. So rectus abdominis will have its own fascial layer, but its fascial layer is made up of all these different things. Does that make sense? Because remember, look at Gray's and where it says, oh yeah, it attaches in through the abdominal fascia into the linea alba. This is basically a representation of that. Not necessarily. All right. Any other questions on this? 1.5 for 3. That, yeah, if you want. All right. Any other questions on abdominal fascia? Have we tired abdominal fascia? Yes. I'm sorry, please. So So remember, this is a cross section. Okay. So I basically did that, and I'm looking down and in. Okay. Makes sense. So basically, first picture, I did my cross section up here. Second picture, I did my cross section down here. All right. Everybody good? Yeah. Yes. I was going to say the same. Yep. Yep. All right. Inguinal canal. So inguinal canal is basically just going to be an open space, and it's very important because it's going to be a passageway for several different structures. Okay, so inguinal canal is going to contain the genital branch of the genitofemoral nerve, in the male anatomy. So we're going to draw a little male symbol here. It's also going to contain the spermatic cord, in the female anatomy, it's going to contain the round ligament of the uterus. Those are going to be the big ones. Okay. Now, with the round ligament of the uterus, understand that's only going to be in females. Obviously, males are not going to have that. Spermatic cord, males will have that. Also understand that spermatic cord and the inguinal canal, more specifically, is going to be the area of dissension for the testicles. Now, the testicles during the development cycle actually start out in the posterior abdominal wall, and then they descend down through, and they actually gather layers of fascia and layers of peritoneum as they descend down into the scrotum. Okay, does it make sense? So those are going to be the big pieces of content. Also, what we're going to see, and you can kind of see it in this picture more than the others, is that I'm going to have two large vessels that go underneath this inguinal canal, because as you can see, the inguinal canal is kind of made up of the free edge of external abdominal oblique. We're going to draw that in here in a second. Underneath this canal, my femoral artery, my femoral vein, my femoral nerve are going to pass through down to my lower extremity. You guys probably covered that a tiny, tiny bit in test and measures. And we'll draw that in a little later because we're going to draw in, probably here in about a month or so, we're going to draw in what's called the femoral triangle. Okay, so those are going to be the big content structures for my inguinal canal. Everybody good with this? Yep. So femoral artery, femoral nerve, femoral vein go under. Genital branch of the genitofemoral nerve, spermatic cord, round ligament of the uterus go through. Okay? Make better sense? All right, no problem. All right. So what we're going to do is we're going to draw in a couple pelvic structures here first. So OF is going to equal something called the obturator. Foramen. Obturator foramen is simply going to be, we've already encountered the word foramen in the past, right? Foramen just means opening, right? Foramen magnum, vertebral foramen, transverse foramen. Foramen just means opening. The obturator foramen is going to be an area where all of my obturator named structures pass through. So we're going to see a couple muscles here when we hit the pelvis, obturator internus, obturator externus. They're both going to basically cover the obturator foramen. Obturator artery is going to pass through the obturator foramen. Obturator nerve is going to pass through the obturator foramen. Okay. What I'm also going to have here right on top of this structure here, okay, and this structure here is my pubic crest. I'm also going to have something called a pubic tubercle, which is going to be this little bump. So PC is going to be my pelvic crest. And PT is equal to my pelvic tubercle. The other big landmark we're going to see here is a landmark you guys are probably familiar with tests and measures. We kind of already discussed it in here just a little bit. This is going to be my AS, IS. That's going to be my anterior superior iliac spine. Now, for this picture, like I said a little bit earlier, the inguinal canal is going to be kind of made up of the free edge of external abdominal oblique. But this picture, if I draw in external abdominal oblique, it's going to completely mess up the picture. You won't be able to see anything underneath of it. So just understand that this picture does not have EAO. But the free edge of external abdominal oblique is going to create, and basically is going to kind of wrap under, for lack of a better term, and create that inguinal canal. So what I'm going to have here, I'm going to try one thing. I'm going to try to get some different color if I can. Not even going to work. Nope. I'm going to make another video of this with some color in it. I promise you. So we're going to work from deep to superficial here. So this muscle, these straight lines going into the transverse plane, you guys can probably already guess what that's going to be. Transverse abdominis, that's right. So this is going to be TA. Now you remember me talking about the arcuate line and how basically the arcuate line means that those muscles start to curve downward. What we see is transverse abdominis starts to arc downward and attach into the pubic tubercle. So we kind of have this arcing motion happening here. All right, it is 2 minutes till. I will draw up a video for this and everything else we missed today, and I'll post it on YouTube as quick as I can. Cool? I think our friends out there are getting a little anxious.